important functions that you and I take for granted every day, right? And so, when you want to talk, a particular part of your brain kind of activates. The electricity in that part of the brain sends signals to various different parts of your body, including the muscles that help you move your mouth to talk. And so this is all really important because when that electricity goes wrong, right, when those signals go wrong, you can have a multitude of different neurologic diseases. But in my world, right, this is exactly why patients have seizures, because it's abnormal electricity. Okay. And then in addition to, and then this is a picture of what a nerve cell looks like, right? And so it's really important to kind of understand these different parts, to really understand how the nerve cell works. And so without getting into too much detail, have a nerve cell body, which is also called the soma. And then there's a long portion here called the axon. And the axon is the part of the cell that the electricity travels along very fast. And then when it reaches what's called the axon terminal or the synapse, which is the connection between two nerve cells, it releases a bunch of chemicals, which allows the electrical signal to be converted to those chemical signals and then back to electricity at the next cell. And so again, that's kind of the basis of neurophysiology, is how these cells interact with one another. So again, the electricity firing in the nerve cell itself down the axon to a chemical signal in the synapse at the end of the nerve cell, and then back into an electrical signal at the next nerve. And then there are various different parts that help make this operate more smoothly. So you have what's called the myelin sheath, which is basically, you can think of as insulation of the wires. So if you think again about the wire that goes to your cell phone that you charge every night, the coating on the outside helps that electrical signal go from the wall plug into your devices fast, and that's basically the equivalent of what the myelin is on the nerve cell. It helps that electricity go smoothly and go fast, because you don't want to be waiting when you want to talk 5 minutes for the electrical signal to get to the actual muscles that move your mouth and tongue and all the other important parts that help us talk. So, all right. So, as I already kind of mentioned, there's this term called synapse. And so a nerve synapse is basically the connection between the two nerve cells. So when that electricity, as I mentioned, reaches the end of the nerve cell, then it goes into a chemical signal, and that's something you may have heard of before called a neurotransmitter. So neurotransmitters are chemicals that carry that electrical signal chemically to the next nerve cell. So the neurotransmitters are those chemicals that help in the transmission from one nerve cell to the next. And there are a lot of different diseases of neurotransmission. So some of you, if you watch TV a lot, may have seen commercials, for example, for antidepressants, which are actually drugs that work on neurotransmission. So they affect the chemicals and the chemical signals between cells. And so the synapse is where all of that happens, which is the space where the two nerve cells are very close to one another, but not exactly touching. So that's kind of the idea behind neurophysiology at a very basic level in terms of what is going on in the brain, in different parts of the spinal cord and all the other nerves that we use to do movements and sensation. It all has its basis on that concept I just talked about, which is, again, the electrical to chemical to electrical signals. And it's the basis for how our entire nervous system works. In addition to the nerve cells themselves, there are also these cells that can be electrically active as well, called glial cells. I'm not going to spend a lot of time on this, but just wanted to kind of mention a few things. So there are cells called the ependymal cells, which are cells that help secrete what we call cerebrospinal fluid. This is the fluid that is very clear and water-like that helps to kind of cushion our brain, and is also a way that we can detect disease in neurology. Excuse me, there are tiny little projections on those cells called cilia that help to move the CSF throughout the system, which is really cool. And how, that fluid kind of moves around and helps to shield the brain, and also is constantly replenished. So you also always have enough cerebrospinal fluid. There's also cells called microglia, which are basically the white blood cells of the brain. So the brain is very unique in the sense that the white blood cells that you have floating around your blood that help to fight infection, when you have a cold or the flu or COVID recently, it's different in the brain. So the microglia serve basically as that white blood cell function, and they basically help to clear the brain from anything abnormal. So not only infection, but also things like when cells die and there are products left behind, they basically eat and destroy those so that there's not dead nervous tissue kind of just sitting around. And so they're really important in inflammation, which again, it has to do with fighting infection in particular. All right. And then we talked a little bit about that kind of special nature of the brain. So that has to do with something called the blood-brain barrier. So that's where the blood, which helps to provide oxygen to your brain, where it connects to the actual brain tissue itself, it's very tightly regulated as to what substances, can go into your brain. That's why infections of the brain compared to infections of your lungs or your urinary tract, UTIs, why they're so much more common, because infections can easily get into those organs and into those places. But the brain is very unique in that the blood-brain barrier is so tight that it doesn't let, things like germs into that area or bacteria into that area. And so the cells that help to create the blood-brain barrier are called astrocytes. And these are very important and the most common other cell besides the nerve cells themselves. And then the oligodendrocytes and the Schwann cells, as I previously mentioned, provide the myelin, right? So that's that white coating that helps kind of insulate the wire and helps the electricity move smoothly. So we call the cells oligodendrocytes when they're in the brain or in the spinal cord, which we call the central nervous system. And then we call them Schwann cells when they're in the periphery. So the nerves that are here in your arm that help your arm move are coated in those Schwann cells. So neurophysiology is really about understanding how all of these cells work together, again, with the basis being that electrical chemical transmission that I talked about earlier. And then just to be a little bit more specific, I don't want to, again, get into too much detail, but the electrical firing of nerve cells is something we call an action potential. So when nerve cells are kind of at rest and they're not being used, there's about what we call minus 70 microvolts of activity. So that means there's a negative charge on those nerve cells. And then there are signals that can kind of slowly raise that charge up to around negative 55, which we call a threshold. So what that means is that there are different nerve cells, again, talking to one another. And if a bunch of nerve cells talk to one nerve cell together and they say, hey, I want you to actually fire your electricity so that you can activate the cells that are downstream or down the line from you, then they kind of slowly help to raise that electrical potential from a minus 70 to a more positive value. When you get over 55 or when you get to 55, then you have what's called an action potential, which is this rapid increase from negative 55 to a positive charge for a very short period of time. And during this time, there are a lot of ions, so sodium, potassium, a lot of the electrolytes that you guys drink and things like Gatorade, and you put salt on your food. This is why all this is so important to the brain, because those chemicals, the sodium and potassium in particular, cross over the nerve cell, and that's actually what creates the electricity, which again then travels down the nerve cell to the next cell. And then once the nerve cell has done its job and sent that electrical signal, we have to basically get that nerve cell ready to be able to fire a nerve signal again in the future. And so what happens then is a process called repolarization, which is this downslope here, where we're basically trying to get the nerve cell back towards minus 70. And so there's a chemical process to reset that nerve cell back to by its minus 70. That way, when it's time again, that nerve cell can fire again to be able to do its important job. And as you can imagine, this is happening thousands of times, sometimes a second, because these action potentials are so tiny, tiny short. They occur on the order of about a millisecond or less. And so you can imagine that in a millisecond, you could fire 1,000 action potentials in a second. And so your nerve cells are constantly doing this, right? And when you're using a part of your body, there's a lot more action potentials going on in the nerve cells that help to do that particular function. So for example, when I want to move my right hand, the part on the left side of my brain that helps to move that right hand is constantly firing these action potentials to help me make those movements. And so this is the basis, again, for how all of the nervous system functions and how it can really go wrong. And as we talked about, there's the resting membrane potential, which is about minus 70 microvolts. So that's where the nerve cell sits when it's not doing anything, right? So when it's just kind of resting, it's not trying to fire a signal, it kind of hangs out at minus 70. And then the membrane potential is basically the difference between what's going on outside and inside the cell. So when it's minus 70, that's what's going on inside the cell. So it's a negative charge compared to what's going on outside. Okay. And as I mentioned previously, all of the basis of this is based on these different ions that can kind of cross through the nerve cell to carry the electricity. So during the time when the nerve cell is firing, right, so from that resting potential of minus 70 up to that very high positive charge, which is the action potential, the ion that's helping that happen is sodium, right? So sodium is going inside the cell. And then to get back to that minus 70 state, right? So once we're like, hey, we're done with my action potential, I need to get back to rest so that I can get ready for the next time I need to do that. The way that happens is the sodium actually starts to go down. So instead of the sodium rushing into the cell, the sodium is pushed back out of the cell, and potassium actually comes into the cell. And that basically returns the cell back to that minus 70. So again, these ions are kind of crossing really quickly, right? Because again, the whole process that I'm talking about happens on the order of a millisecond or less. Excuse me. All right. So we talked a little bit about this previously, but again, the way that the chemicals cross the brain, or the way that the electricity gets transmitted into a chemical signal, is by something called neurotransmitters. And the neurotransmitters themselves are chemical substances that basically, again, carry the electricity across the synapse, right? So the synapse, again, to remind you, is that space between the two nerve cells. And this is just to present to you kind of all the different neurotransmitters, but there's lots of these different named neurotransmitters. So some of these might seem familiar to you, or you may have heard of these. So one that might be very commonly, some of you may be familiar with, is something called epinephrine, right? So some of you may be familiar with this in the setting of an allergy. So some of you may have allergies and need to carry an EpiPen, right? So an EpiPen is an epinephrine pen. And so the chemical in that is epinephrine, which is the same chemical that is used in the neurotransmitters. It's the exact same chemical. And as I mentioned, for example, antidepressants, which is a medicine that some of you may be familiar with if someone you know takes one, or if you've heard about it on TV from drug ads, which are there. Serotonin is the neurotransmitter that a lot of those drugs work on. And so as you can see, the different nerve transmitters work in different ways, right? And in different parts of the nerve cells. So for just a couple other examples, acetylcholine is the nerve that helps to dilate and squeeze on your blood vessels, which is how we maintain our blood pressure. Dopamine is something that gets released both for memory and also for reward, right? So meaning that when you have like that most favorite like food that you all enjoy, when you eat that, there's actually a release of dopamine that tells you, oh man, this is really enjoyable, right? This is what makes this my favorite food. And that is how you kind of not crave it, but want it again, right? Because your brain actually has a reward system to say, hey, I really like this and I'd like to have it again. And so you can see there's a variety of these different neurotransmitters that do various different tasks. And again, we think about these all the time because a lot of the medications, for example, that I use in my practice as an epilepsy doctor actually work on these neurotransmitters. So some of them can either help the neurotransmitters or actually inhibit the neurotransmitters to achieve the goal of preventing patient seizures. Okay. All right. So that's kind of just a very brief kind of overview of the nitty-gritty of neurophysiology, kind of what we think about. And that's the science, right? So whenever we talk about something in medicine, you have to remember that there's a science behind everything that we're doing. So although I'm a doctor and I talk to patients and I prescribe medications and I write orders for tests and read tests, right? Everything that I do is based on, understanding kind of the science and the physiology and the anatomy behind what I'm doing. So that's why it's all of the science that you guys learn in high school is so important, right? When you think about chemistry and physics and biology, right? So those are the building blocks by which you can learn more complex science, when you can learn neurophysiology or neuroanatomy, for example. So that's kind of why all of this is so important, even though it's like, hey, what does that have to do at all with treating patients, which is what I do, obviously, on a daily basis. So we're going to talk about seizures and epilepsy now. And so I'm just going to start really briefly by talking about, what is epilepsy and what is seizures. And then I'm going to move to the Kahoot real quick just to kind of give you guys a chance to participate a little bit and also think about some of the things that we'll talk about in terms of what I do on a daily basis. So epilepsy is basically a disease or a disorder in which patients have multiple seizures throughout their lifetime. And seizures are basically a sudden alteration in some sort of characteristic. It can be behavior, or it can be a jerking movement. It can be odd tastes in the mouth, for example. For every patient's seizures, it can be a lot different. But all of those alterations has to do with the electrical functioning in the brain. And so what ends up happening is a bunch of the nerve cells, we've been talking about how they talk to one another. They should take turns, like I talked about, right? So one cell should fire that action potential and then talk to the next cell and the next cell and the next cell, right? That's how our brain works. But when a bunch of cells all try to talk at once, right, they all fire all together, right, as opposed to playing nice in the sandbox and kind of talking to one another at one at a time. That's what we call a seizure, right? That's when there's a bunch of synchronous, meaning all together the same electrical activity, usually in one part of the brain, or it can be in the whole brain at once. And so that causes an actual disease state where someone does something, whether it's that they stop talking or, again, they have jerking movements. But that's the physical manifestation of that abnormal electricity that's going on in the brain. And so that's what we call a seizure. And again, epilepsy is where people over their lifetime have seizures unexpectedly and usually multiple times throughout their lives. And so it can be from a wide variety of things, but basically it's anybody who has this multiple and repeated seizures through their lifetime. And the thing I always tell my patients, and that I'll tell you, is every brain is capable of having a seizure, right? And so every person on this earth, can have a seizure in the right circumstances, right? So if we, for example, and obviously I don't condone any of you doing this, but if you use enough of certain illicit substances, you can cause yourself to have a seizure. Or, for example, if you use a lot of certain illicit substances and then stop using them, you can also have a seizure, right? Those sort of things are related to the substances that people are using. That's not epilepsy, right? That's just your brain having a seizure due to the fact that you've done something to yourself, right? In this case, either using a substance or using a substance and then stopping it suddenly. But people with epilepsy have seizures, again, like I mentioned, without warning, right? So these are not people who are necessarily using illicit substances or taking, medications that they shouldn't. These are just people who are walking down the street or driving to work, and then all of a sudden, boom, they have a seizure out of nowhere, right? And so those are the patients that I treat on a daily basis. So that's just a little primer on epilepsy, kind of the definition. So I'm going to switch real quick to the Kahoot. So again, if any of you are familiar with this, Kahoot is basically a little kind of quiz show sort of format. And so what I'm going to ask you to do is pull out your phone or open another screen if you can. And then, oh, sorry, you guys can still see my screen, correct? Sorry. Yes. Hopefully.
Yeah, we can.
Okay, perfect. So what I'll ask you to do is just, you can either scan the QR code if you're able to point your phone there, or if you don't, you can just go to the website kahoot.it and then enter the 6-digit code. So I'm going to give you about 2 minutes just to kind of join. I am paying attention to the chat. Sorry, I was telling my friends here that I have 2 screens, so I sometimes look over to the right because your guys' chat and everything I have on my second screen. So if you have any questions as I'm going through, feel free to throw them in the chat because I am watching. Excuse me. So basically what's going to happen is it's a little bit of a competition. So the way that it works is it'll show you a question. It gives you 20 seconds to answer the question. All of these are multiple choice, and they all have to do with epilepsy and neurophysiology. Just to give you a little bit of a taste about some of the other things that I do. And I'll talk a little bit after each question just to kind of illustrate the concept. But the faster you answer and the more accurate you answer, the more points you get. And there are a total of 9 questions. So we'll go through, again, all 9 and then give you guys a chance to kind of have your hand or try your hand at some epilepsy factoids. All right, so let's see. We've got 36 in the thing, and I've got 25. So I'm going to give it about 1 more minute or so just to see if there's any stragglers that want to join. And so you're going to see the questions on my screen, but you'll also on your phone see the choices in addition to seeing them on. But remember, you'll have to tap on your phone or whatever screen you have the game open on, just so you know. All right. All right, so I think we'll get started. You can join in the middle, so if any of you haven't gotten in here, it's totally fine. The pin will stay at the top, and you can join here in the middle. So, all right. All right, so as we said, this is neurophysiology. And again, it'll give you 20 seconds, and I'll read the question as well. So, the first question is, how common is epilepsy in the United States? So in terms of number of people in the U.S. living with epilepsy. And again, if anyone wants to jump in the middle, the pin, I'm sorry, is at the bottom. I thought it was at the top. But it's at the bottom if you need to jump. Perfect. So 12 people got that correct. So yeah. Epilepsy is super common, right? And so epilepsy is the third most common neurologic disease, right? So the first most common neurologic disease is headache, right? Which is migraine. And the second most common is stroke, right? Which a lot of you may be familiar with, disruption of blood flow to the brain, particularly in older folks. But epilepsy is the third most common disease in neurology, and it affects about 1% of all of the U.S. population. So depending on which figure you use, it's somewhere between 3 and 4 million people, or about 6 out of every 1,000 people. So if those of you who are in various different high schools, if you have roughly 1,000 people in your school, at least 6 of people in your high school will walk around and probably have seizures or epilepsy, whether you know it or not. So it's super common, and so you can imagine the need for people in the epilepsy field, not just for doctors, but for all of the various different health professionals that I work with is super high given this prevalence of this particular disease. Okay, so it's going to show at the end of things the scoreboard. So the top 5 people after each question. Okay, next question. So, at what age is it most common to have epilepsy? Under the age of 5, between 5 and 10, between ages 15 and 25, or between ages 25 and 35. So this would be most commonly to have your first seizure or to get diagnosed based on just looking at when people commonly present with having epilepsy. Yeah, so surprisingly it is very young, right? So epilepsy is most common in infants, actually. So usually between the ages of 1 and 3, that's the most heavy time for patients to develop new epilepsy compared to later in life. There are still people who present or have their first seizure in childhood, right, between ages 5 and 10, which we think about as kind of elementary school age, or during your guys' age group, right, so teenagers into high school and early college, and also in my age group, I'm 33, so kind of the older, young adult group. So people can develop epilepsy throughout their lifetime. It's just most common in children. So as you can imagine, people who do what I do in epilepsy are needed throughout the spectrum of care, right? And so if you are thinking about a job where you work with kids, you can, work with kids who have epilepsy, right? Because it's super common to have epilepsy as a child. But there's also adults, right? And so, in terms of interest in medicine, people can go to pediatric neurology, which is a lot of epilepsy, or adult neurology and do epilepsy. Okay. Oh, we had somebody jump from the bottom or jump from below. All right. Question 3. What should you never do when you see a person having a seizure? So if you're walking down the street and see someone having a seizure, what should you never do? Call 911, roll them on their side, try and stick an object in their mouth to prevent them from swallowing their tongue, or move objects away from them. Great, perfect. So the majority of you know that. That's perfect. So seizure first aid is something that everyone should know, regardless of whether you know someone who has epilepsy or not, because you never know where you might be when someone may have a seizure. And if you know what to do or know how to help, it's really important. So patients who have seizures are usually extremely embarrassed when they've had a seizure, particularly in public around people that they're not familiar with. But the thing you should never ever do is try and stick something in someone's mouth while they're having a seizure, because it's a huge choking hazard. There is this common myth that people can swallow their tongue. I can tell you it is physiologically and anatomically impossible to swallow your tongue. And so it used to be out there that people who had seizures would swallow their tongue if you didn't try and stick something in their mouth to prevent their tongue from being swallowed, but that never happened. But the things you should always do is make sure the area around someone who's having a seizure is clear, right? So, for example, if someone were to have a seizure in a classroom, like in your high schools, you should move the chairs away, the tables away, so that they don't hit their heads, right? Especially while they're having a seizure. Sometimes people throw up during seizures, so you always want to roll them on their side so that that vomit doesn't get into their lungs. And of course, you want to provide them help. So certainly call 911 so that people can arrive who are able to help them. So perfect. All right, another new name to the board. All right, question 4. What test does not measure the electrical activity of nerve cells? So we talked all about electricity, right? So there's all these different tests that we use. So is it an EMG, an SSEP, an EKG, or an EEG, right? So which test does not measure the electrical activity of nerve cells? I tricked you. I figured I would get most of you on this one. So it's important to know these abbreviations, and I did assume a little bit that some of you might be familiar with some of these, but I didn't want to put the long names because it kind of can give it away. So as we talked about, everything about the nerve cells, or the nervous system and neurophysiology has to do with how those nerve cells communicate with one another. So we have lots of different tests that can actually measure how those nerve cells are working. So there's what's called an EMG, an electromyogram, which is basically a test where we shock the nerves in the arms and in the legs to see how they're working. And we can measure how well they're working by how the muscles jerk, and also by recording stickers, putting stickers on the part of the body that actually has the movement to see how well that's working. So that measures nerve function and how the nerves communicate with the muscles that they're actually trying to move. There's also something called an SSEP, which is called a somatosensory evoked potential. It's basically a fancy name for how we measure people's sensation. So when you take a pin and you prick your finger, there's an electrical signal that goes up your arm, into your spinal cord, and into your brain. So we can actually put an electrode on your scalp and actually stick a pin in your finger and measure the electricity when it gets up here. So it's called evoked because we're making that signal happen by actually poking your finger. And somatosensory is basically the fancy word for sensation, right? How we feel pain and temperature and touch. And so basically we're able to measure that electricity as it travels all the way up into the actual brain. And then my personal favorite, the EEG, the electroencephalogram, is basically where we put a bunch of stickers on top of the head and measure the electrical activity of the head, and can be very useful for people who have seizures. An EKG is probably something some of you are familiar with, actually, which is an electrocardiogram, which is where they put stickers on your chest to measure your heart rhythm, right? So that doesn't measure the electrical activity of nerve cells necessarily. That's more to do with the heart cells, which are these specialized cardiac cells that can conduct electricity, but they're not nerves per se, at least the nervous system. All right. Question 5. In which lobe of the brain is it most common to have seizures from? So you have 4 lobes to your brain. You have a temporal lobe beneath your temporal, an occipital lobe here in the back of your head, a parietal lobe kind of above your ear, and then a frontal lobe right behind your forehead. So you can have seizures from any of these, but which one is most common? Let's see if anybody happens to know this. Good, so 5 people. Yeah, so the temporal lobe right here beneath your temple is the most common area to have seizures from, but you can again have seizures from anywhere in the brain. It's just if you look at all people with epilepsy, the temporal lobe or temporal lobe epilepsy is the most common. All right. So I'll move beyond that. All right. Question 6. What symptom is not something that someone can typically do during a seizure, right? So can people have shaking movements? Can they have uncontrollable laughter? Can they see colorful balls of light in their vision? Can they experience traveling numbness or tingling or pain? Or can they have staring? Or are all of those potentially things that people can do when they have a seizure? So again, which symptom is not something that typically someone does during a seizure? Great. Yeah. So they're all seizure symptoms, right? So the most common seizure type that people are familiar with is what we call our grand mal or convulsive seizure, which is where people have jerking movement. But you can have seizures where people just laugh uncontrollably out of nowhere. People can have visual seizures where they have colorful balls of light that kind of bounce around in their vision. They can have sensory seizures where they feel a weird sensation. It can be a numbness, a tingling. Sometimes it's painful. And yes, we will have questions at the end. And then the most common seizure type in kids is called absence seizures, which is staring spells. So perfect. All right. Question 7. How does epilepsy affect patients' lives? So when you have epilepsy, how does it affect people? Are they restricted from having certain jobs? Do they have a lower life expectancy? Can they not have children or family? Or they may have restrictions in their driving. Yeah, so absolutely. The most common restriction and the way that probably the single hardest thing for me to talk to patients about is the fact that they can't drive if they have seizures that are not controlled. There are a few jobs that it's very hard to have if you have epilepsy, something like being an airline pilot. Although I think most of us would agree, we probably don't want to fly on a plane if the pilot has a seizure. But really there's no restriction in what they can do. Patients with epilepsy do not have a lower life expectancy. They actually have normal life expectancies and actually do quite well into older age. And women in particular can definitely have children and families, even despite the fact that they may have epilepsy or seizures, excuse me. So, okay. All right. Okay, we're coming to the home stretch. Last 2 questions. What other health problem is common in patients who have epilepsy? Do they often have high blood pressure? Do they have mental health concerns like anxiety or depression? Can they have diabetes, or is cancer more common in patients with epilepsy? Yes. Beautiful. Yeah. So this is really important. Patients who have epilepsy have very high rates of things like anxiety and depression. And so a lot of my job also is to talk to patients about their mental health concerns. And I actually do a fair amount of treatment of patients with mental health concerns as well. So if any of you have an interest in treating or may have mental health concerns yourself and can relate to those people, this is a super high area of need in which you can still be involved with patients who have neurophysiologic problems in a very positive way. So again, mental health concerns are super common in patients with epilepsy. All right. All right. And finally, what is not an option for how we treat epilepsy? So how can I treat a patient? Can I give them medications? Can we do a surgery for them? Are there electrical devices for epilepsy? Can we do therapy for seizures? So like talk therapy, or all of them are options. Beautiful. So yes, they're actually all options, right? So the most common treatment for epilepsy is patients take medications, but we can do different types of surgery, including implanting electrical devices in the brain to help prevent seizures. And there's actually certain types of seizures, which we call non-epileptic seizures, which respond very well to therapy. Cognitive behavioral therapy, which is a type of therapy to treat mental health concerns. So they're all technically options for patients who have epilepsy. All right, perfect. So we've got Ashley with 6 out of 9 correct. Great job. And another 6, but probably just a little 5, John and Mater. I'm sorry if I butchered that. But great, 6. And Ashmita, great job, guys. It's so awesome. All right. So I'm going to switch back. I'm just going to close this actually, but great job. I hope that that was helpful or interesting to learn a little bit more. So I'm just going to go through a couple of quick things about epilepsy and then I will take questions. As Sarah actually, Dr. Schaefer put in the chat, the symptoms that patients have with seizures can tell us where they're coming from. And that's in the case of what we call focal seizures, which is where one part of the brain has the seizure. Often this is due to injury, like a stroke or bleeding in the brain, like if someone has a bad head injury. But patients can also have generalized epilepsy, where the whole brain starts the seizure at once, as opposed to it being localized to just one part of the brain. And the way we diagnose epilepsy is really complicated, but really the point that I wanted to make with this is that even when patients have a seizure, as we already talked about, if they did something to cause themselves to have a seizure, like we talked about using some illicit substances, for example, then that patient doesn't have epilepsy. But if a patient has a first-time seizure and then we do testing to figure out that they are high risk to have another, then we diagnose them with epilepsy. Or if people have multiple seizures, as we already talked about, without reason, that's consistent with the diagnosis of epilepsy. But there's a lot of other things that can mimic seizures, including episodes where patients pass out, migraines, problems with sleep, movement disorders, which are Dr. Schaefer's area of expertise, right? So there's lots of different things that can actually look a lot like seizure, but is not seizure. So there's a lot of interplay here between different neurology in what I do. And so when we do tests on patients with epilepsy, I already mentioned my favorite test, which is the EEG, which is where we put a bunch of stickers on the head and watch the electrical activity. So here's a picture of a young girl having an EEG. So you can see there's tiny electrodes that we just place right on the scalp with some tape and some paste, some special paste. And then this is the diagram of all the electrodes that get placed on the brain. So as you can see, there's a multitude of electrodes throughout the entire brain, and including some that are close to the ear. And we look at the different waves that come about in the electrical activity. So you can see here, there's different types of waveforms. Oops. Sorry. There's different types of waveforms. There's slower waveforms that occur when you're asleep and faster waveforms when you're thinking. So all of you listening and hopefully thinking about the things that I'm talking to you about probably have beta activity, this very fast wave activity on your EEGs right now, if we were to connect you up, versus when you're sleeping or in a deep sleep in the middle of the night, you'll have this very slow sleep. So this is actually what an EEG looks like, just to give you an example. So when I actually look at a patient's brain waves, this is what I look at. So this is someone who's awake. These big triangular waveforms here are actually your eye blinks. So we all blink our eyes all the time. And so that actually shows up on the EEG. And then these are nice, healthy looking, what we call alpha waves, which is the predominant frequency when patients are awake. And then this is what people look like when they're asleep, right? So when you're deep in sleep, like I said, you get these large, big waveforms, which we call delta waves. So they're bigger, right? They're taller and they're much slower, right? They happen at a much slower rate compared to this wave where you have multiple in a second. This is only about 1 per second. And these purple lines measure seconds, just to be clear, right? So each purple line, between purple lines is 1 second in time, right? And so you can see within 1 second here, there's about 9 to 10 waveforms versus here, there's just one. So it's different states when people are asleep versus awake. And then again, all of the medications that I use to treat patients with seizures all have to do with that neurophysiology we talked about at the beginning, right? So this is a diagram of a nerve cell and then the chemical signals that get released from the cell to the next cell. And each of the names in these boxes is a different medication that can be used to treat epilepsy. So as you can see, there's a variety of different medications that work at different places in that electrical to chemical to electrical signal to help prevent patients from having seizures. And then, as I mentioned briefly in the Kahoot, there are devices that we use. And so these are the 3 different devices we use for epilepsy. We have what's called a VNS, a vagal nerve stimulator, which goes in the chest and then goes on the vagus nerve, which is a long nerve here in your neck, that provides calming signals to the brain, which can help prevent seizures. We have an RNS, which is basically where we can put electrodes directly into the brain if we know where the seizures are coming from. And that device actually can sense the seizure and then shock the brain from having the seizure. And patients are totally unaware that this is happening. So it's really cool. And then we have deep brain stimulation, DBS, where we implant 2 electrodes deep inside the brain, which are constantly kind of providing electrical impulses to the brain to help basically calm the brain again and prevent patients from having seizures. So these are different electrical devices that can be surgically implanted to help patients who have seizures that do not respond to medication. Okay, a couple of last things. So for those of you that are looking for a cool volunteer opportunity or a way to potentially get involved in epilepsy or find a little bit more, the Epilepsy Foundation of the United States is a super active nonprofit in epilepsy, and they actually talk all about different career paths within epilepsy as well. I listed the website here for the Connecticut Epilepsy Foundation, but there's an epilepsy foundation for each state in the U.S. as well as international chapters. And so it's definitely worth a look. They have a lot of information. And they're constantly looking for volunteers, both for events. They have a walk to end epilepsy every year, throughout the year. And they also run a lot of charity events. And they have the need, for example, for patients to be able to be driven to and from work. You know, as we talked about, patients with epilepsy sometimes can't drive. And so here in Connecticut, there's actually an army of volunteers that actually will drive patients to and from work, to help them be able to go. So it's a really cool, organization to potentially look into, and they're very active in the U.S. and very good advocates for patients who have epilepsy. So just a couple of notes about my path, just so you kind of understand. So I'm originally from Ohio, as I mentioned earlier on, if some of you were in the room right when we started. So I grew up in a town in southwest Cleveland, Ohio, called Strongsville. So I graduated back in 2008 from high school. I did 4 years of undergrad, right? 4 years of college, basically, at Miami University of Ohio. And I did a degree in both economics and biochemistry, because I actually wasn't sure if I wanted to go to medical school. And my backup plan was to go to graduate school for economics. But that's a whole nother story. I went to medical school though, and I graduated in 2016, and I went to the University of Toledo, which was 4 years. And then I did my neurology residency and my fellowship in epilepsy at Yale, which is why I'm still here in Connecticut. And that was a total of 6 years, right? So 4 years of neurology, residency, and 2 years of training specifically to treat patients with epilepsy. So as you can see, it's a long path. But what I wanted to say is that I work with a vast team of professionals. So I work with advanced practice providers, so think people like PAs and nurse practitioners, which obviously have a shorter educational cycle but are very needed in epilepsy and in neurology in general. I work with nurses and licensed practical nurses who help me to get medications for my patients, who talk to my patients when I'm not available about their concerns when they have a seizure. They help them with paperwork related to getting their driver's license back and just for being that ear to listen to patients when they have a concern. I work with a team of social workers who help out with patients who have a variety of different issues. If they can't work because their seizures are so frequent, they connect them with mental health care and different services throughout our communities. I work with a team of therapists who treat patients with non-epileptic seizures, but also treat my patients who have epilepsy, who also have things like anxiety and depression. I work with researchers who are a variety of different types of scientists who do research in epilepsy and neurophysiology. I work with EEG technologists who actually do the study, right? So I mentioned that we do that EEG where we put all the stickers on the head. There's a technologist that actually hooks the study up and monitors the study and knows how the study functions just as well as I do, in fact, and sometimes better. And so that's another great career path. And then I work with engineers and also business people because all of those devices I mentioned are manufactured by device companies. And I interact with the business people who are involved in those companies as well as the engineers who come to our clinic and work with us to help the patients who have those devices to make those devices work the best that they can for them. I work with a variety of people, and as Dr. Schaefer said, I think next week, and that's why I asked about the panel earlier, there'll be people who are going to talk about these different career paths, not just obviously me being a physician. So anyway, sorry I blabbed on for as long as I did. I didn't intend to do that, but I hope that some of that was interesting. So I'm happy to take questions. So I see a hand. I'm not sure how we typically do that, but I see a hand. So I think Sia or Saya. I'm sorry if I totally butchered your name. What can I
Hi.
do for you? Hey.
So my question is kind of related to your last comment about the people you work with.
Yeah.
Like how you said you work on developing devices, do you try to approach towards frugal approaches when you're trying to work towards these devices? Like how sustainable are these options?
Yeah. So you're talking about kind of the costs associated with epilepsy care as a whole. Is that kind of
Well,
specifically what
yeah, and the
you're referring to?
environmental impact. Yeah.
Oh, environmental impact. Yeah, great. So, from a device standpoint, the devices last for a really long time. So most of the devices are implanted for patients' entire lives. They do have batteries, but the batteries actually only have to be changed about every 15 years. So for an average epilepsy patient, they only go through about 3 to 4 batteries, in their lifetime, depending on when they had the device placed. So I think the environmental impact of our epilepsy devices is not huge, but I agree it's definitely something that needs to be thought about. And I'm sure that the companies, if they don't have, would be very interested in having people to think about the environmental and long-term impacts of those devices. But yeah, we and certainly consider cost in general too, right? So epilepsy care, unfortunately, as most healthcare in the United States is, can be very expensive. The medications can sometimes be very expensive. Certainly these devices are expensive as well. And so that's always a factor that we have to think about. Luckily, epilepsy, can be very deadly for patients, right? And they can lead to a lot of injuries. And so insurance companies are happily, usually willing to pay for, the care because it's better to pay for a patient to have a medication that may help them stop having seizures than having them have a seizure and end up in the emergency room like once or twice a week because they're having seizures so frequently. But that's a great question. Certainly something I've not thought about. And I think next week at the career panel, if there's anyone that's from the device companies or who has some of my EEG technologists actually know those people very well. That might be a great question to ask them too. I'm personally not aware of them thinking about that, but I'm sure that they do.
Okay.
Yep,
So nice to hear.
no problem. Any other questions? You can feel free to type them in the chat as well.
Dr. Trainer, I actually had a question myself.
Yes, go ahead.
So I was wondering if there's like a reason why seizures mostly occur in the temporal lobe.
That's a great question. There's a lot of hypotheses. The most likely reason is that so the brain itself, when there's an abnormality associated with seizures, there are some that are just more common than others. The most common one associated with seizures is something we call mesial temporal sclerosis. The very inside part of your temporal lobe is very, very sensitive to changes in oxygen and infection and things like that. And so sometimes when patients are very young, like when they're actually being born, there's this hypothesis that, during the birth process, sometimes the oxygen level can dip, and, we're not aware of that because you're not necessarily monitoring, baby's, oxygen when it's, being born. And so there are a fair number of people walking around that have mesial temporal sclerosis, and that's very high risk to have seizures. And so that's the hypothesis as to why it's the most common, just because mesial temporal sclerosis is the most common. But other than that, for patients who have temporal lobe epilepsy, for example, where they don't have that abnormality, it's still the most common, but we don't actually really understand why. It's also has to do with epilepsy being so heterogeneous, right? So the causes are vast and many. There's genes and genetics that can cause epilepsy. There are things like tumors and strokes which cause epilepsy. There are, systemic diseases that people can be born with, some of which are genetic also, and some of which are not, that can also cause epilepsy. And there are certain brain structural problems that you can be born with and not be aware of either, where you actually may go for a vast majority of your life without having any problem until you have your first seizure, which again can happen at any time. But yeah, it's a very dichotomous field, or heterogeneous field, I should say. What else? Any other questions?
I have a question. It's not
Yeah,
necessarily related to epilepsy, but
that's okay.
so you showed a slide on the frequencies of
The
like
EEG.
different activities, and there was
Yeah.
one about unifying consciousness. What does that mean?
Oh, unifying consciousness. That's a great question. The idea is basically that if you measure EEG in the brain itself. So when we do scalp EEG, right, the skull itself, right, the bone actually filters out some of these frequencies. So we can't see those. So gamma activity is thought to be the electrical activity that underlies consciousness, right? So the fact that you and I are conscious and talking to one another has to do with the fact that if you measure it in certain areas of the brain, you're going to see gamma activity. Whereas if you measure those same areas of the brain in someone, for example, who's in a comatose state or who is in a persistent vegetative state or something like that, they don't necessarily have gamma activity. So the gamma is thought to be, again, the idea or the underpinning of what we understand to be consciousness. But as you can imagine, if you think about what does it mean to be conscious, right? It's a very complex question. And people actually argue a lot, and there's a lot of things to think about in consciousness. There's religious beliefs associated with consciousness, like what does it mean to be alive? There are personal beliefs, right? Certain people have beliefs about the way that they would want to live their lives. This has to do with a lot of neurology. Patients often will say, oh, if I can't talk with my family, for example, I wouldn't want to live, right? And so this idea of what is consciousness and what's important to people in terms of their function is very complex. But the specific on this slide has to do with just the gamma activity, from an electrical standpoint, is thought to be the activity of consciousness. That's all.
Okay, thank you.
You're welcome. No problem. All right. I think I got to 8, but I'm happy to take more questions. I have nowhere else to be at the moment. I have a 2-year-old running around, my wife.
Can I ask another question? I'm
Of
sorry.
course you can. Yep. What's up?
So my question is, do you know what gunpowder is? But I think you do, but so there's
Gunpowder, like to fire guns?
yeah.
Yes.
So there's certain types of gunpowders which are made from lead dust, and I think usually manufactured in California, which have this one
Okay.
label like mentioning that this is like one QR code mentioning like there are several health risks involved with using gunpowder, so you
Yep.
should check out the QR code before using it. And I think
Okay.
one thing mentioned that staying too much in contact with the lead dust can cause you to have tremors, which I think is kind of like seizures. So do you think things like this, like involving yourself with guns or like gun violence, can help trigger seizures in any way?
So that's a complex question as well, because I think there are, I mean, not to get into too much into the weeds, but there's a lot of patients who have, for example, like non-epileptic seizures, which are often triggered by things like PTSD, which can be, related to being a victim of gun violence, for example. It's very well known that, for example, children who are unfortunately the children who have been involved in school shootings and things often have higher rates of mental health illnesses, which can lead to both having non-epileptic seizures, but also have a higher incidence of developing seizures later in life. Now, with regard to the question specifically about the lead, right? So a lot of the heavy metals, not just lead in general, but mercury is the same way. Carbon monoxide, actually. So the carbon monoxide, regardless of how it causes poisoning of your actual blood, there are different heavy metals and substances in general which can deposit in your brain, and they can deposit in different areas of the brain. One of the areas of the brain which it often deposits in is an area called the basal ganglia. And those basal ganglia help to coordinate movements, kind of normal movements, which is why a lot of them are associated with tremor. But they can be, those heavy metals, can be associated with seizures as well, depending on if those metal deposits end up in different parts of the brain. So seizures come from the outside of the brain. So like we've been talking about neurophysiology, the connection between the nerve cells, most of that happens, at least in the brain, on the surface of the brain, the part that we call the cortex. So we think that seizures come from the cortex. So unless something is damaging the cortex, there's not really a risk for seizures. But if something is damaging the cortex, there's definitely a risk for seizures. That's why, for example, patients who have a disease called multiple sclerosis, which is an inflammatory condition where your immune system attacks the deep parts of your brain, those patients actually don't have seizures very often because the cortex is actually not being attacked by multiple sclerosis. It's all the inside part of the brain. So I guess, that's a long answer to your question, but the heavy metals can certainly be associated, with neurologic disease in general. It just kind of depends on where that heavy metal is being deposited in the brain. So. Ashmita, I think you have a question too. Mm-hmm.
Thank you, Dr. Trainer.
Yeah, no problem.
I was wondering, so when someone has like repeated seizures and they could potentially fall into a coma, is that more common for like the body to fall into that comatose state, or is it more common for like a physician to medically induce a coma so that?
Oh, that's a great question. Yeah. So when patients have continuous seizure activity or very frequent seizure activity, something we call status epilepticus, which is basically like the idea that there's continuous seizure activity, we do sometimes treat patients by placing them in medically induced comas. The idea being is that if we're able to suppress the electrical activity in the brain enough that we stop the seizures, that we basically allow the brain a chance to kind of reset and relax for a period of time. And then when we kind of take them out of that coma, we obviously have seizure medication on board. And some patients do present, meaning their first time they ever have a seizure, they have status epilepticus, which again is this continuous seizure activity. Now, continuous seizure activity itself can also disrupt consciousness because when you're having a seizure, right, it disrupts your ability to form new memories and things like that. And so depending on how widespread the seizure is, and again, how long it is, the seizure itself can disrupt your consciousness to the point where sometimes patients do kind of present in a semi-comatose state. So yes, that can happen. It's not super common. Most patients who have a seizure will recover normally after about 30 to 90 minutes, depending on how long the seizure was, where it came from, that sort of things. Most patients will not go into status epilepticus, but yeah.
Thank you.
Yep, no problem. All right. I think I'm getting the stage hook, which is fine. So I think they have my email address. I know Shreya does, and the rest of the folks do as well. Dr. Schaefer does as well. So if any of you guys think of any other questions, you can always contact me. Okay.
Thank you so much, Chris. That was
Nope.
a really, really amazing lecture.
No problem at all.
Awesome.
Anytime.
Dr. Trainer, thank you so much.
No problem, guys. I hope you all have a wonderful rest of your night.
Thank you. You as well.